in kind of one-way format with just the presenters talking to increase the quality of the audio. But feel free to enter any comments that you might have in the chat box. We've got a number of polls that we'll have folks answer. I will monitor the chat so that we make sure that any questions or comments get acknowledged and answered. It's my pleasure to introduce Dr. John Pender, who's a senior economist in the Resource and Rural Economics Division of the USDA Economic Research Service. And he's leading research on rural wealth creation in the United States. He's an author of more than 60 peer-reviewed publications related to both international and domestic rural development, including a recent ERS report on regional approaches to rural economic development and the initial impacts of the Delta Regional Authority. So with that, I'll turn it over to John and let him have at it.
Thanks, Scott, and thanks to both you and to Rosa for organizing this. This is really amazing technology. I'm just learning as we go here, so I hope people will bear with us. I feel a little bit like a radio disc jockey here speaking out and no one can answer back, but I guess it's good that we have your ability to chat back. That's really, we're hoping for lots of feedback, so this is great. So this is, as Scott said, we're launching a survey. I should introduce myself a little bit. I'm with the Economic Research Service at USDA, and I'm working on rural development issues there. I'm leading ERS's program on rural wealth creation, and in that program we're considering wealth in a sort of broad way. Some people talk about comprehensive wealth, for example, which includes not only sort of financial assets and marketable physical assets, but other kinds of assets that communities and people have as well, like social capital, human capital, and so on. So the idea here is that we want to try to understand linkages, relationships between rural community wealth of different kinds and healthcare provision. So that's the title of the survey. So what's the kind of background here and the rationale for what we're doing? Probably as most people know, anybody that's studied rural regions knows that access to rural healthcare services is limited in many rural areas. It's a major concern for a lot of rural communities, and we know that the needs for rural healthcare services are only going to be growing as as the baby boomers retire, for example. There's a growing need and maybe an opportunity for rural communities to grow economically, provided that they have adequate services, not just healthcare, but other amenities and services that every aging population might find attractive. So it's important, of course, healthcare is important in its own right as far as contributing to the quality of life, but it also can have important implications for economic development. And as a matter of fact, I mean, as we were trying to, we started out this thinking about this survey, not necessarily focusing on healthcare. We wanted to, select a sector in the economy that was important in rural areas, and that we saw where there would be opportunities, where there has been growth, and where there are opportunities for growth in the future as an economic opportunity. And it's actually, if you look at data, which I did some review of secondary data and literature and so on, the healthcare sector is one of the areas that you find growing in many rural areas. And so there can be opportunities there, especially, as I said, as people are retiring. You have now the Affordable Care Act and so on, that will be affecting the kind of demand for healthcare services in rural as well as other areas of the country. So that's kind of how we got interested in focusing on this topic. And then in reviewing the literature, we found that there is a substantial literature on rural healthcare, of course, and there's quite a bit that looks at especially rural physicians and what are factors that affect the decisions of physicians to locate in rural areas, whether they're first in terms of recruitment, and then also in terms of integration in communities and retention. There's a fair amount of literature on that, but I would say almost all the literature that I've found on that is really looking at the issue from the point of view of physicians or from medical schools and so on, and it's finding, that factors such as where a physician grew up, if a physician grew up in a rural area, they're more likely to locate in a rural area. If they went to medical school that had a rural component, or a residency training in a rural area, that affects it. So there is knowledge about those sorts of things, but there's less information from the point of view of rural communities themselves. And I guess one of the underlying hypotheses that I have is that rural communities, or at least not all of them, are sitting passively and hoping that someone will come and be a healthcare provider in their community. At least some communities are probably trying to do something about that. And what assets they have and that they can build on in that process is part of what we want to study and understand. How do the assets and investments that rural communities make affect their ability to sort of attract providers, healthcare providers, and not only physicians, but there are other kinds of providers, allied health professionals, nurse practitioners, and so on, dentists, and others. So that's kind of kind of the underlying rationale, that there's a gap in the literature that doesn't really look at these kind of community level factors, and also there's a limited literature that looks beyond just physicians. So what we're planning to do is to try to address this, what we see as a knowledge gap, through it's actually a two-stage survey process. So first we have in mind a telephone survey that would be conducted in a substantial number of communities, about 150 communities, and that would be conducted in 2012. And then the idea is that we'll follow that up based on what we, some of what we can learn in a short survey, to conduct follow-up field work in 2013. So for that work, we've teamed up in Economic Research Service. We're teaming up with Iowa State University, both with their Center for Statistics and Survey Methodology, and with the Survey and Behavioral Research Services group, which will be implementing the survey. And so I want to acknowledge Jan Larson from the Iowa State Behavioral Research Services group, who's also online here. And Jan, I don't know if you want to say hello, if we can hear you.
Oh, hello, John. Yes.
Okay,
And actually, I should mention that also in the room we have Shirley Huck, who is the assistant director here at our center, and as well as Allison Anderson and Jody Fox, who are both project managers in this organization. So we're glad to be here, and thank you.
Okay. So I'm going to go ahead and give the presentation, but if we have questions, Jan and others may also respond to some of the questions. I would encourage you, as Scott said, we're not set up to hear comments from everyone who's online, but there is the chat room on the side of your screen, on the left side, and please, feel free to put in any comments that you may have. I see that it looks like everyone has filled out the two polls that I was asking about, sort of basic information on who's on this webinar. If you don't mind identifying yourself further in the chat, that would be great. It's totally optional, but in terms of where you're studying or whatever, or if you're a researcher at a university, it'd be great to know where you are, but no requirement there. So let me just go forward here to the next slide. So this next slide is the objectives of the survey, and basically kind of drawing upon what I said on the previous slide, that we think there's sort of a lack of information about what rural communities can do to recruit and retain healthcare providers. So that's kind of the primary objective. This this first objective, we're trying to improve understanding about how the assets, again, broadly defined to include, kind of a wide range of types of assets and not just, physical infrastructure. But how do the assets and investments that rural communities make affect recruitment and retention of healthcare providers? Sort of the primary objective. And then we recognize that how much we can learn about this in a cross-sectional survey will be somewhat limited because it's a dynamic issue. But we also want to learn a bit about the effects that rural healthcare provision has on economic development in rural communities. And so we do have some questions that are oriented towards that. These could also be part of what we try to explore a bit more. I mean, we can try to explore all of these issues further in the next phase, where we're planning to, in 2013, conduct more in-depth kind of interviews, more qualitative kind of research in a follow-up phase. So let me, Scott, I don't know, okay, if I want to bring in some other polls, should I bring these old ones out or should I leave them there?
You can just drag them right over them. That would be fine.
Okay. Okay, so as we go along, I've got some additional polls that if people want to fill them out, these are about each of the sections. And maybe if the answers aren't clear yet, you can also pose questions. But the first poll is about the objectives. Are we clear about the objectives of the survey and so on? And so then we'll move on from here. Instant feedback. This is interesting. Okay. So next I want to
John,
talk about the study.
Do you want the recipients to? Do you want the participants to see the results or not?
That's okay. Sure.
Just click the broadcast results box if you want them to.
Oh, at the bottom. Okay. Okay, that's already. I guess maybe you checked it. Okay, so I guess they're seeing the results. Yeah. Okay, in both of them. Okay, so next we'll talk about the study approach and what we're planning. So as I mentioned, this first telephone survey is going to be focusing on healthcare providers and community leaders, and we're going to be conducting the survey in 150 towns in 3 regions of the country. Now, first I should say, why 3 regions? Well, we don't feel confident with the budget that we have that we can do a representative survey of towns in all of the country and do justice to the variability that you find in the United States. So we're kind of trying to stretch as far as we can, we think, with what we can afford. But a sample of 150 is a pretty small sample to represent the entire U.S., but this gives us sort of on average about 50 towns in each of 3 regions. We looked at some kind of data that you can find in secondary data on availability of doctors and other kinds of indicators that you can get through the Dartmouth Health Atlas and other sources, and we looked at the variability, and we think we can do a reasonable job with a sample of 50 on average in each region. So, and then the regions that we selected are the lower Mississippi Delta region. So we're not claiming to cover an entire region here in any case, but we're selecting 3 states that are somewhat representative of 3 different regions in each case. So the lower Mississippi Delta, we're going to be working in Arkansas, Louisiana, and Mississippi. Then the Southern Great Plains, which we're including Kansas, Oklahoma, and Texas. And then the Upper Midwest, we're including Iowa, Minnesota, and Wisconsin. And really, these regions, they represent quite a variety of situations. Certainly, there's a lot of poverty, especially in the lower Mississippi Delta and the Southern Great Plains, and you also have a very kind of limited access to healthcare services in many towns in those regions. The Upper Midwest is a kind of contrasting situation where you have better access to doctors and so on average, but there's also, again, quite a bit of variation. So it's interesting to have these kind of contrasts. You also have quite a bit of variation across these regions in terms of ethnic makeup, sort of levels of poverty, ethnic makeup, educations of the population, indicators of social capital, and others. Another factor that we looked at was where are places of the country where you see significant sort of rapid growth occurring in the healthcare services sector. And in many of these places, I didn't put any maps on here, but we actually mapped out some of the data where you had growth rates for healthcare services and healthcare employment, and like parts of Kansas, for example, and Texas, so parts of the southern Great Plains and the Mississippi Delta especially showed up in terms of where you have significant numbers of counties with kind of rapid growth taking place. And then again, there's a lot of variation within these regions, so that's part of what we want to study. So that's the kind of overview of the regions, and then as I say, we'll be conducting surveys in randomly selected towns in these 9 states, and then we'll be following up with more in-depth interviews, field interviews, and so on, in up to 40 of those towns in the following year. So that's the overall study approach. And then talk about the sample selection. Let me just pull in, we have a poll here about that. Okay, so the next poll is asking how well do you think the approach will serve the objectives of the study. So I've pulled that one in now as well. Okay, so now I'm going to talk about the sample selection, and within these 3 regions, we're going to be selecting towns, and the basis for selecting towns, or the primary sampling unit, will be zip code tabulation areas. These are, they largely correspond to zip codes, but they're zip codes as of the 2000 census. That's at least the zip code tabulation areas that we're using. And part of the reason we're using that is there's data within the Dartmouth Health Atlas that are down to the smallest level of aggregation in the Dartmouth Health Atlas's zip code tabulation areas. And these correspond roughly to a town. We've looked through the data, and we found, of course, many cases or some cases for larger towns where you have more than one zip code tabulation area within the same town. And so in our population frame, we've aggregated those places where you have multiple zip codes to the same town. But then we've decided to restrict the size of towns that we're looking at, so that we want to focus on towns that are large enough that it's sort of reasonable to expect them to be able to recruit healthcare providers. People that are just out in unincorporated areas, not in a town, and so on. We're not, or in very small, very tiny towns. We expect it may not be such an issue or such a feasibility, I guess, of being able to recruit healthcare providers. And then once you get above a certain size, you find, for example, above 20,000 in population, virtually every town above 20,000 has a hospital. So it's like more than 95%. So above a certain size, I mean, there's still issues, of course, with healthcare access, but some of the issues where we think the town can, in its assets and what decisions are made by community leaders, are going to be more affected by, in this range, this kind of intermediate range of town size. So we're restricting the population that we want to focus on to kind of small towns, and we're also trying to leave out the high commuting areas, so basically suburban populations that have a high commuting dependence on large urban areas with more than 30% dependence for their employment on commuting to an urban area. Those are being excluded from our sample as well, or from our universe.
Are you
So
planning to look at population change as part of your sampling strategy? You know, for example, with a random sample, you might get all towns that are declining or all towns that are increasing in population, and actually the ability to recruit providers might be fairly dependent on population trajectory.
that's a good question. We haven't discussed that. That hasn't been part of what we were planning, but it's something maybe worth considering. So I mean, yeah, it's something we can at least look at, you know, and see what kind of variation we might get with our approach. But so let's see, what was I going to say about that? So basically, we have data in the Dartmouth Health Atlas on the rural-urban commuting area codes that allow us to make these distinctions, to screen out the suburban areas with high commuting dependence and also the population ranges. So taking those criteria for these 9 states in these 3 regions, we basically have a universe that includes about 6.1 million people in 809 towns in these study states. And so then for the sample selection, we define the strata, and the strata will, of course, include the 3 regions themselves would be separate strata. And then within each region, we plan to stratify by whether or not the town has a hospital. So there's about, in this overall 9-state region, about half of the towns in this range have hospitals and half don't. And so that's a kind of interesting breakpoint there to try to understand, you know, why some of these towns, you know, obviously there's a population size effect there, and the towns that are towards the upper end of that 20,000 limit are the ones that are more likely to have a hospital. But it would still be interesting to understand more about, for towns that are of similar size, why some have hospitals and some don't. And then we were working, one of the statisticians at Iowa State in their Center for Survey and Statistics methodology is devising the sample approach where the sampling will be, there'll be a sampling allocated among the strata based on the population size of towns and the number of physicians per person. So that number of physicians per person is kind of part of what we want to try to understand, you know. So we want to look at the variability in that variable one as a kind of factor to take into account to define the kind of efficient sampling approach. So let me, if I were actually giving a real seminar, I guess at each of these points I would stop and ask if there were questions, you know. So if there are questions, you know, please send them in the chat box. I don't know, Scott, I haven't been following the chat box, but do you think there are any?
Tim just put up one about, you know, maybe stratifying by whether there's a hospital due to the fact that physicians are unlikely to choose to locate if there's no hospital in town.
Right. Okay. That's what I'm saying here is that that's part of the stratification is towns with versus without a hospital. And so we have a good balance there because about half of the towns have a hospital and half of them don't.
Well, I guess
So,
he's saying that I guess he's saying that you might not find much going on in towns without a hospital.
oh, well, I mean, we've had a lot of discussion about this, and I don't know whether Jan would want or someone in the Iowa State group want to speak up, but it is an issue that we talked about. We actually thought a rural clinic might be, you know, we thought a minimum kind of level of infrastructure would be towns that have at least a rural clinic, because you may not have a hospital, but you might have a rural clinic. And we're concerned that if you screen out places that don't have hospitals, then you're missing a lot of the population that is actually most in need, you know, most limited in terms of rural health care. So they may not have a hospital, but they may be trying to do something to either to get a hospital or to attract, you know, providers through small rural clinics and so on. So that's kind of
That's a similar point that Gina is making too, that providers can be tied to clinics in her chat comment.
Right. So let's see, did I pull in the next? Okay, so there's another poll about the sampling approach. Yeah, so you can see that poll about the sample selection approach. And then let me go to the next slide. Okay, so now the respondents. So we have basically two questionnaires in mind and two types of sets of respondents. One are healthcare providers, so including physicians, dentists, nurse practitioners, and physicians assistants, and hospital and clinic administrators. And we have sets of questions for them, and then for obvious reasons, we're including them in the sample. And then the other is community leaders and other stakeholders that would be involved in recruiting and trying to integrate and retain healthcare providers. So that could include the mayor, the public health agency, economic development agency, various, private nonprofit groups, either chambers of commerce. There could be other groups involved. So some of this, there will have to be some research done for each of the communities that's selected. We have to go and learn something about each community, what we can through web searches, looking at directories, maybe talking to some key informants to find out, especially on this issue of the stakeholders, who are the people that we need to talk to. So.
And Cornelia Flora had a question about whether wellness providers will be included in this, and I think there is a survey that targets those specifically.
So by wellness providers, you mean, maybe can we get a clarification on that? To what degree are wellness professionals included? So yeah, maybe I can ask Cornelia to clarify what she means by that. Massage therapists, acupuncturists, and so on. Well, I would want to, we haven't decided, I guess, on that, or I mean, I guess we hadn't included those in our initial thinking on this. So I don't know whether Jan or any of the others from Iowa State want to comment on that, but I guess the concern, one concern might be is, how wide do we cast the net, and it becomes, maybe difficult to cover too many different types of groups.
Yeah, I think you might find that where they're coming from could vary quite considerably across different wellness professionals. In my travels through the rural areas, I'm noting that a lot of the shingles that are hung out with the doctor's office seem to be associated with people that have maybe come from quite a bit further away, whereas some of the types that Neil is talking about seem to be maybe more, sort of from the town or from the region, just based on kind of last names.
Well, I see that Cornelia is saying it might be good to find out if they're there rather than survey them. So I do think we have some, when we get to the survey questions, we'll see there are some questions that are fairly broad about what kind of services are provided. I can't remember, when we look at it, we'll see which ones are provided. So we do have a broader perspective when we're asking like what's actually provided in the community. But then in terms of who we're surveying, I think we're a little bit more narrow because of these considerations. I guess one issue I would raise that a few people have already raised to me is whether pharmacists should be included in the survey, and I know one person, a few people have suggested that, so that would be good to get feedback on from the participants today as well. Okay, so anyway, so the idea is that we're going to be selecting, after this initial identification of who the respondents would be, then we would sample from that list up to 15 per town. At least that's what we budgeted for. I mean, we're actually planning on a smaller average than that per town. So then coming to the questionnaires, I'm going to provide, actually, let me move this. Okay, yeah, so in the questionnaires, I'll provide some overview, and then we'll look in detail at the questionnaires. So there are two questionnaires. There's, as I mentioned, one for healthcare providers, and then one for community leaders and other stakeholders. The length, this is all, we're subject to the Paperwork Reduction Act requirements of the federal government. So we, and it's also, I guess, good survey practice to keep surveys short, especially with very busy people like healthcare providers. And so we're targeting an average of about 20 minutes and 30 minutes max. We've done, I think the folks at Iowa State have done some initial practicing with some of the questionnaires that we've shared, and I think they've met that target. But we had to do a lot of, we had lots of ideas about what we would include, and we had to scale back quite a bit, especially on the health providers questionnaires, to make sure we can get within that range. So each of the questionnaires, I don't know if people had a chance to look at them, but there are some common sections in both questionnaires. There's a section on community assets, for example, a set of questions that ask about sort of different types of assets, people's perceptions about how the community, how well it's providing some kinds of assets. Then there are questions about the healthcare in your own town, so about the quality, access, and their changes in the past 10 years. And then demographic information on respondents, so the age, gender, and so on, education, ethnicity, some of the usual, I think, questions there.
Gina had a question.
Sure.
Gina had a question about length of tenure in the community.
And
whether
needs changes. I think, I mean, it's a good point, and it's useful to have a longer perspective. But I think since we're asking this, in a general survey, I mean, there's 2 points. One is, when it comes to sort of analyzing things, or how well can we understand what's going on, it becomes sort of more difficult as you go further back in time, I think, to sort of understand the context when you're understanding, what's happened in the last X number of years. So, and then the respondents, you would have fewer respondents, obviously, that would be able to respond to longer time periods. So,
being married to a provider, it's interesting how dependent they are on insurance coverages by major employers in the area. I noticed that you didn't ask about changes in insurance coverage, whether people had healthcare insurance provided by their employer. So, a policy change by the employer of, okay, we're gonna cover dental, but not optical or whatever, can put somebody out of business. And I wondered if you had thought about adding that in terms of your changes, just the coverages. You have, right, sort of other types of things.
Yeah, I mean, we have to go back and look at that. I thought we had something about the insurance as part of understanding the changes in the past 10 years, but maybe we need to look at that again.
Well, you said insurance company policies. This is really employer policies about insurance that I'm talking about. So the company policies haven't changed, but the employer's willingness to pay, or the number of employers offering insurance, has changed.
Right. Okay, I think that's a good point. So we'll take that into consideration. So we're also recording the comments that we're having, and your comments and so on. We'll get a recording of that as well?
Yes.
Okay, great. All right, so let me move on to the next slide. Providers questionnaire. So this is, again, just an overview of the different sections kind of the questionnaire, and then we can go into more detail. So each of the questionnaires has screening questions. They're somewhat different for providers, kind of obviously, but these are the kind of questions that the screening questions we think we hope to get from every respondent, even if they don't participate in the entire questionnaire, then at least we know something about who didn't participate, and also just to find out if they're the right people, we're talking to the right people, for the survey objectives. And then we look at questions about their background, of course, education and prior experience, prior locations, and so on. A lot of questions about their current practice, and then the major emphasis here is really on what's affecting why the provider is working in this town. And so we have a kind of a pretty long list of factors that we ask about, and then we ask them to say something about what are the most important factors affecting recruitment and retention of providers, what changes have occurred in their own practice in the past 10 years and reasons why, questions about their satisfaction with working in this town, both sort of in terms of professional as well as other kinds of aspects of satisfaction, and then involvement. So one of our hypotheses is that providers that become more involved in their communities as community members and community leaders sometimes become more integrated and more likely to continue working there. So there's some small quantitative and qualitative studies that cite the importance of that, and so we're trying to kind of broaden the understanding of that beyond just a few case studies. And then questions about the plans to retire or change practice in the next 5 years. So that's kind of the overview of the providers questionnaire. Then stakeholders, community leaders questionnaire, there's a set of screening questions again. And then we ask about their assessment of the overall quality of providers, and then kind of general questions about the success in recruiting, integrating, and retaining providers. So that's sort of an overall assessment. And then we ask more specific questions about the most recent recruitment effort. So was there an effort recently? What type of provider or providers were they trying to recruit? Who was involved in that? How successful was the recruitment? Is the provider still working in this town? And then the reasons for success or failure of the recruitment and retention. So that's getting the community's perspective, community leaders and other stakeholders' perspective. And then we ask about providers that may have departed from working in the community in the past 10 years and why, what plans they have to recruit providers in the next 5 years, and then what are the most important factors affecting recruitment and retention. So that's the overview for that. Then okay, so now we come to the actual questionnaire. So let me pull those. Let's start with the the providers questionnaire.
Yeah, and I had a question about on the providers on page 8, questions 30 and 31.
Okay, can I think I lost, let's see, I clicked on it, I brought it over, and now I don't know if it's hiding behind. Scott, can you see it? I don't know if you can find the provider's questionnaire that I just pulled over.
Let's see, where did that go? Yeah, well,
while I'm minimize the PowerPoint.
Well, there it is. There it is.
Okay, yeah.
Oh,
so
while you're fiddling with that, one of the things that I had noted on the survey was you're asking about where they the type of area where they did their residency, and also the type of area where they grew up.
Right.
And you're asking them to sort of characterize them as rural, suburban, or urban. I think you might be better off just asking them where they did it. I've found in prior work that one's perception of rural is somewhat subjective. It depends on what your comparison area is. So, for example, here in Michigan, somebody might think they're rural when they're living in a a community or a county that has 75,000 people in it, and still they think they're rural. Whereas if you took that same county and plunked it down into western North Dakota, it would be the metropolis of the region.
Right.
And the big city. So you could just simply ask them, could you please name the town in which you did your residency, and then actually use more objective criteria to classify those, the town and state that they did their residency, and also, where did you grow up, town and state or country, as the case may be.
Right. Yeah, okay, I don't know, Jan, or do you have any comments on that, or?
Jan muted her microphone.
Oh, yes, yeah, I'm here. It just took me a while. I was making some notes. That's a very good point. I think people's perspectives can be quite different, and it certainly is something that we can incorporate. I do think, as far as the location in which a person grew up, there can be quite a variety, and people don't necessarily fall into one neat category, and so it might be best to actually get specific information and then classify it afterwards.
Okay. So I don't know, Scott, I don't know what you would recommend, I don't know if we want to just go through every question, or I don't know if we can assume that people have had a chance to look at this.
Well, I don't think there's time to go through every question. We've got about 15 minutes, so
right.
Maybe zero in. I think the group might be interested in, you've got a couple sections where it's the same across both surveys, kind of this community capitals one.
That might be good.
Folks could take a look at that and give some feedback on the wording of some of those.
Yeah, okay, that's a good suggestion. So question number 14, which is where we get past the screening questions and we're into the main questionnaire. There's a big section here with community assets.
Jan, can you mute?
Yep.
Okay, so I guess I could try to pull this down so they can see more of the questions. Let's see. Yeah, I guess. Okay. There we go. Scott, are you doing that? I guess you must be doing it.
I'm trying to help you out there.
Thanks. Okay, let's just go up a little bit so we can see. So basically we're asking about a range of different types of assets, and basically the scale is from strongly disagree to strongly agree. And then so here's a set of questions asking about, for example, infrastructure, access to telecommunications, infrastructure, sort of recreational and outdoor activity, amenities, access to financing for small businesses. Where's that green arrow? How do we get that green arrow back on there?
Good question. I don't know where that went. You can also use the drawing tools. Maybe those would come up. One question, it'd be interesting to get, since Cornelia Flora is on, and he's done a lot of thinking about this kind of thing. What about these, maybe go down to questions Q and R. I think those could be quite important. This town respects and values cultures of diverse community members it is difficult for newcomers in this town to be accepted by long-term residents. This town welcomes people of different ages and cultural background. You know, I guess the you know how one experiences that is often dependent on whether one is in the majority or not category. So I'm just wondering if there's a better way to get at that. You know, the general population would still be able to answer. You know, it might be. You know, I don't know. I'm struggling with how one could answer, because I'm thinking that everybody's going to strongly agree with this when it may not be the case. And so, are there other sort of more objective questions that one might ask, like you know, and again, I'm drawing a blank on how to do that. So you know, maybe others can chime in.
Yeah. So we'll see.
And then Tim has a question about spouse relocation assistance.
Yeah, I think when we talk about, we do ask some questions related to spouses when we're asking about factors affecting providers coming to the community, but yeah, I'm not sure. Well, we'll something to think about. Community assets. Yeah, no, it's a good question. I don't have a ready answer to it, but I think it's a good question. Okay. I mean, obviously, the problem we have is like there are just so many. I mean, there are many different kinds of assets and factors here that we could ask about. So we probably cut about 1/3 of them out. I don't know where Jan remembers. We had a larger number, and then we think we've got, you know, indicators of several different types of community assets that we think are important, you know, including indicators of social and financial, physical capital, I think some cultural ones.
John, we did have originally about twice this many and had them divided roughly equally among 7 or 8 different forms of capital. And we still have a balance among the different forms of capital, but we cut down to 2 or 3 per category just because of space. And so it can be difficult to make sure that you include the different, the variety of issues and subject matter that really needs to be included. We did meet with Cornelia Flora, got some good advice and suggestions from her back several months ago in terms of how we might craft this, but there certainly is room for improvement, and we're always interested in better ways to ask questions.
Yeah. I would invite anybody that if you think of something, you know, if you have time or you're looking at the questionnaire later, you know, send us an email. I didn't think to put my email address on here, but it's jpender@ers.usda.gov. And so appreciate any further comments that, you know, people have beyond this webinar. But Scott, related to your question about, you know, getting the diversity, I think that's a real challenge with, you know, we have to recognize that we have a kind of, we don't have a random sample of these communities, you know, and the respondents. We're looking at healthcare providers and we're looking at community leaders and kind of, so we can't claim that we're understanding kind of the diversity of opinions and we actually, I was trying to be sort of entrepreneurial here about this survey. I was looking at the possibilities of, you know, conducting another survey that would be of actual, you know, individuals or household heads or something in some of these places. But I think with the budget situation that we have now, it's probably not going to happen, but or at least not in the next few years. But so So that's, I think we're going to, no matter how we, all of these questions, basically, we have to recognize that there's going to be a diversity of opinions within these towns that, and we're not necessarily reflecting the diversity of the populations in these towns. Okay, so I wonder if I should, if there are no other thoughts about these asset questions. Then we come to the sort of healthcare. We ask about access and quality, just from poor to excellent. And then we come to some questions that are about different components. So this may be where we get into some of the broader kinds of healthcare providers or wellness providers. I don't know. Let's see. Yeah, we have sort of in this list of different types of services related to healthcare. There's, pharmacies, emergency healthcare, physical therapy, drug and alcohol abuse, and so on, alternative health options, nutrition guidance, and so on. So it's a pretty broad spectrum there, and we're asking, does the town have this, yes or no? And then if it does, then to rank the sort of quality of it. I think I'll go on from there. Anyway, so you get the idea of that. Then we ask about changes. So what's happened in terms of changes in availability and changes in quality of healthcare overall? And then if the quality improved or the availability improved, we have a set of questions that might relate to that. Did they improve because a new hospital or clinic opened? There are new professionals that have come, new facilities. Is there better access through telemedicine? Are there changes in government policies, changes in insurance company policies? That's looking at sort of the improvement side of things. And then we have a similar question for if the quality or availability has declined, then was a set of questions. Did a hospital or clinic close? Did providers leave town? Is the equipment or are the facilities deteriorating? Is it government policies or insurance company policies? I think, Scott, your point about employer policies might also be something to add there. Then we ask about the cost, same kind of question, have the costs gone up or down in the last 10 years? And then what are some of the factors if the costs increased? What were the, again, a set of factors that may have contributed to that?
On the equipment piece, and I'm not a healthcare professional, so I don't know, but it seems like asking about equipment deteriorating might get a different answer than asking whether the equipment is up to date. So I mean, you could have a, yeah. Is the equipment or facilities at your hospital deteriorating or inadequate?
Maybe inadequate is sort of, wouldn't that sort of cover up to date?
It might, but it might not too. I don't know. Again, I'm not an expert in this area, so it seems like you're sort of looking, you're asking. I don't know. It seems like they might be interpreting that as what is there now, versus the fact that they don't have certain types of tests that they can do or the right kind of X-ray.
Although in these questions we're trying to ask about changes rather than the level is the we're not. We have other questions earlier where they're asking about their perception of the level of quality or something, but here we're asking about changes in quality or service in the last 10 years. So
And if it's so it might not be a decline. So yeah, maybe this isn't the right place to put that. Because okay, so we have the same X-ray machine that we had 10 years ago, and it still works. So I guess it hasn't declined. But meanwhile, X-ray technology has changed dramatically, and we're
Right.
not at the cutting edge anymore.
Right. Well, we can think about whether that's, it's we're trying to, yeah. Well, we'll think about that, whether we want to try to get at that as well. Um, how well we get at the sort of overall changing environment and innovation or whatever. Okay, so then the next part we're asking if there's a change in availability, quality, or cost. Now here we're trying to get at sort of in a very, kind of preliminary and simple way, what impacts do people kind of perceive, at least on the attractiveness of a community, how do these changes in healthcare access and quality, so on, affect, attracting people to the community, for example, whether it's young families or could be young families or retired people, new businesses, or it may be, on the opposite side and maybe affecting whether people move away or whether businesses leave town. So we're just asking perceptions of how much effect these kinds of changes in healthcare services may be having on these kind of indicators of kind of community development. Then we go on to more specific questions for the healthcare providers. So what their background is. Scott, you were already raising the question about this urban, rural, suburban. There might be an interpretation problem there. So we'll think about whether we want to ask a more objective, specific question there. Again, on where they grew up, could be a similar issue. How would you describe your current practice? So whether they're working as part of a group practice or in an independent practice in a hospital and so on. And questions about sharing duties, on-call duties with other providers. This issue about locum tenens and one of the issues in the literature about difficulty of attracting rural healthcare providers, at least physicians, is that they may feel that they're not able to take time off if they're like the only physician in their practice or the only one in town or something, so that's kind of part what we're getting at there. How many hours a week do they work in this town? So I mean, part of what we recognize is that some communities may have doctors that only come in for certain days of the week or whatever, and so that's what we're getting at here in terms of how many hours are you working here or in nearby communities. Okay, then now we're coming to a long list of sort of community level factors that may or may not affect, why the provider is working in this community. So from their familiarity, influence of spouse or family members, size of the town, nice place to raise a family, university opportunities, natural amenities, and so on. There's a, kind of broad set of things.
Yeah, we are coming to the end of the hour. Do you want to ask your last two poll questions?
Okay, sure. I guess we haven't had a chance to get through all this, but maybe put this here anyway.
And I'll go ahead and put the summary evaluation on. Then if people want to answer those, and then we can go on a little bit longer too. But sometimes people have to get off. So, oops.
Okay. Okay, we just covered over.
Yeah. So hopefully that one is. And there's a question from Crystal, which I think is pretty relevant here, kind of raising a point that I brought out earlier. You know, a lot of these the medical doctors in very rural areas tend to be coming in from another country. So, you know, repayment of the J1 visa might be highly relevant for folks in that situation.
Yeah, I think in an earlier version of this we had something about that, and I don't know. Okay, we can. I'm not sure why we dropped that one, but I don't know whether Jen has a comment on that, but I do think that's relevant. Yeah, for sure. There these kind of programs that are, you know, providing loan repayment or visa waivers and so on.
You know, it might be more of a branching type question where you ask that depending on what they've told you. You know, like if it's a stakeholder and they're active, you could ask them that question. If they're not active, don't bother. On the other hand, if it's a provider and the provider's told you that they're from a foreign country, you could ask them, you know, when you moved here, did the community offer to repay, you know, some of your visa costs, visa processing costs, or whatever.
So anyway, so there are some others that we should consider. Then we ask, after this long list, what would you say is the most important factor that drew you here, and then what was the biggest drawback practicing here? Have you considered going somewhere else? And reasons that people may have decided to leave, why they decided to stay. And some open-ended questions about what were the most important factors in recruiting and retaining healthcare providers in general in the town. What's the greatest difficulty in recruiting or retaining? And then changes in their practice in terms of the number of hours of work, changes in their affiliation with other physicians, changes in types of patients that the providers may have been willing to see. Added staff or reduced staff, so get an idea of sort of, you know, major changes that may have occurred in the practice. Upgrades in facilities and equipment. So here's, you know, we're trying to get at some of these issues of innovations and so on, and other significant changes in their practice. And we ask about overall, how satisfied are they with their professional, you know, various aspects of working in this town, the professional situation, opportunities for their family, opportunities for professional interactions and social interactions. How much have you been involved with? Okay, then we ask about sort of kind of involvement in the town, whether first about, you know, professional involvement, you know, working in community health fairs, for example, helping to address a local health problem through a community group, sort of, you know, volunteer activities, and then community activities that aren't necessarily related to health, participation in local organizations, involvement in leadership role in the community, and then plans for the next 5 years. So that's, what are they planning if they're retiring, or if they're not retiring, but leaving, then we want to ask why they might be planning to leave. And then demographic questions, as I mentioned. So that's kind of the physician survey. I don't know if people want to stay on and look at the stakeholder survey, or, you know.
Yeah, I've actually got to run, but if folks want to stay on, that's fine. You know, the system is open and available, so I'll close now, but anybody who wants to stay on and and talk about the other survey, feel free to. Maybe you could put your email address into the chat, and then folks can also download the survey from our website and send you comments later as well. So a couple